Our first presenter is Dr. Rachel Lawson. Rachel Lawson is a pharmacist who has worked in pediatric oncology for over 15 years. She's currently the clinical team leader for oncology at the Queensland Children's Hospital. She has recently completed a PhD through the University of Queensland, investigating the pharmacokinetics and pharmacodynamics of once daily intravenous busulfan in children undergoing hematopoietic stem cell transplantation. She has an avid interest in personalized medicine, utilization of model-based methods for exposure monitoring and pharmacogenomics. Welcome, Rachel.
Thank you very much for having me today. And I'll be presenting my model that I built during my PhD, which was on busulfan. So today I thought I'd first just do a very brief overview of busulfan and what we use it for. And then I'd talk a little bit about the model development, but particularly I'm going to focus on some of the hurdles and learnings that I had during my first model build. So firstly, busulfan. So what do we use it for? So busulfan is used for bone marrow transplant. And what we, in hematopoietic stem cell transplantation, the first step is withdrawing stem cells from the donor. The second step is ablating the bone marrow cells in the recipient. And this is done with conditioning therapy. And this is a combination of chemotherapy, radiation, and stereotherapy. Then we get those stem cells that we had in step one removed, and we infuse them into the recipient. And this is as simple as just hanging a bag of blood at the bedside. And we hope that these stem cells then go find their home in the bone marrow and start to engraft and produce new blood cells. So busulfan, the metabolism is very complex and it's actually not fully understood just yet. But we do know that unbound busulfan diffuses passively through the cell membrane, and then it undergoes, a large portion of it undergoes hydrolysis to the active moieties, which then go on to interact with our DNA and result in apoptosis. So the concentration in the plasma is important because it is passively diffused. The target cells are in the bone marrow, and thankfully this is a really highly vascular organ, but unfortunately our other highly vascular organs, so lungs, brains, liver, experience some off-target toxicity. So the first step in busulfan metabolism is conjugation with glutathione, and this is primarily via GSTA1, but also some of the other GST enzymes can also help. Now, fast GSTA1 metabolizers can, it means that there's often less of free busulfan that's available to undergo hydrolysis to these active moieties, and so less able to be active within the cell. And conversely, if you're a slow GSTA1 metabolizer, then you have more free busulfan and more of these active moieties interacting with DNA. So interestingly though, the GSTA1 activity within a lot of our cells is similar. However, in bone marrow, it's only 20%, or there's a 5-fold reduction in GSTA1 isoenzyme activity. And therefore, you would consider within here, you would have very slow GSTA1 metabolism. And therefore, within these cells, much higher concentrations of the active moieties. And so this is what is thought to give busulfan its specificity for our stem cells. So key points, the concentration of active moieties inside the cell is very important because this is relevant for the number of intrastrand and interstrand cross-links within the DNA. And you need enough DNA damage to cause apoptosis. But we are using plasma busulfan exposure as a surrogate for activity. So busulfan has got a well-established exposure response relationship. So to high exposure over the typical 4-day course increases your risk of liver toxicity, lung toxicity, and transplant-related mortality, and ultimately, unfortunately, death. And exposure that is too low increases the risk of graft rejection, relapse, and also death. There was a large paper published by Bartlink and colleagues, which gave us an optimal exposure target window of between 78 and 101 milligrams per litre by hour. And so that's the background done. But what I wanted to focus on today were kind of more my hurdles. And so the very first hurdle that I had was convincing my supervisors that we actually needed another model. So, in the literature, there's more than 20 population PK models for busulfan in kids. And there were two really big ones. And these were highlighted to me. They said, well, there's these publications which has 674 kids and 1,610 kids. What more can we do? And so I guess for me as a clinician, I'd observed that there was a reduction in clearance over the course of the 4 days. And in the product information, it very clearly said clearance is unchanged over the course. And so I still felt that there was work to do to really look at how clearance changes over the course. Now, in these two large papers, they used a factor to say that the clearance did reduce over time. However, the majority of the samples from both of these studies were from dose 1, and this was also from 6-hourly dosing, whereas we were using once daily dosing. So what we had was we had a unique data set. We had samples with each dose, and we did intense sampling. So we had 7 samples with every single dose. And we had observed, we could show that clearance did decrease, and it was over the course, and it was often more than 10% in most patients. We also could easily collect concomitant drug information, and we also had paired outcome data. So I was able to convince them that we needed a new model. So next, we really wanted to focus on how clearance changed over the course. And so we had to decide on key models to test. So we obviously looked at Michaelis-Menten model, looking at concentration-dependent clearance. And then we also looked at this time-associated model, which had been previously published and is here. And it looks at it in a very similar way to Michaelis-Menten. It just pretty much has time from first dose instead of concentration. And then we also looked at simple factor models as well. So our time-associated model best fit the data that we had, and then it showed that the maximum change in clearance that was expected for an average patient was about 19.8%, and that 50% of this would occur at about hour 50.6 following the first dose, and that there was an average decrease in clearance for about 11% over the course of treatment. But there was variability around that. So this was our final model, and I didn't really want to highlight too much about the final model, but obviously we had a time-associated clearance equation, and we also had a size parameter based on normal fat mass, and we had a maturation component as well. But what I wanted to talk about next was, with hindsight, I would have explored the metabolism of busulfan more. So since we published our model, there's been a model published about glutathione depletion, which incorporated glutathione depletion here and recycling. And it also had compared a time-associated model as well. And it decided to go with this one, but the difference between the two to explain how clearance changes over the course was quite similar. The other thing is metabolite interactions. So there's increasing evidence that the first metabolite can actually inhibit further metabolism of busulfan through competition with GSTA1. And there was a recent model looking at sulfolane, which is a further down metabolite than tetrahydrothiophene. And it found that GSTA1 was a significant covariate in clearance, as well as sulfolane concentration. So I wish that I had looked at the way busulfan was metabolized, and maybe metabolite concentrations and a more mechanistic model. Next, I guess I wanted to just highlight, this was something which I hadn't really considered. We initially built the model with 95 patients with an assay that was performed at one laboratory. And we got the opportunity to include an additional 65 patients, and this was from samples tested at a different laboratory. And both had undergone external validation of their busulfan assay. However, when we performed an external validation using VPC, we observed that the model was not able to adequately describe the data from the data set too. And so we went and we investigated this for quite some time, actually, about exactly why this was the case. And pretty much when we adapted the model to include a different central volume of distribution by data set, you can see here the VPC was considerably improved. And you can see that the second data set, the new data set, the central volume of distribution was about 5 times higher than ours. And so when we went and investigated this further, the hypothesis was that potentially there was an inaccuracy in the assay at higher concentrations at laboratory 2. And there was a publication in 2021 where 25 different laboratories were sent different busulfan samples. And these were the results. And so they accepted plus or minus 15% from the true value. And you can see you'd really want to be, a lab like this where your lower concentrations, which are the circles, are 100%, and your triangles, which are the higher concentrations, are at 100%. But you can see that the majority of labs had significant variability, and you can see that these ones here, that the higher concentrations had lower values than what was observed. And so it's possible, it was thought, looking at quite a few different things, it was possible that this was the reason for what we observed. There were also potential other options, so differences in supportive cares between the groups. There was high use of azoles in one group versus the other, and then potential differences in administration or sampling time, etc. But this was the hypothesis that we think is most likely. Next, I just wanted to mention as well, we had another problem where if you're looking at time-associated clearance and incorporating that in your model, I do highly recommend using differential equations. So the publication which we were using as a basis had not used differential equations. So we didn't initially, and we found that the model was struggling to converge, particularly for a peripheral volume of distribution. It chose it was very high. It was greater than 2,000, and that was considerably higher than what was in the literature. And as soon as we changed it to differential equations, so no other changes, just changing it to a differential equation, it was able to converge at a value which was much more closely aligned with prior literature. And lastly, I just wanted to say, reviewer feedback. I was incredibly lucky to have reviewers who are obviously very experienced pharmacometricians, and they gave me feedback which has really improved my final published model and manuscript. So I just wanted to highlight, don't get disheartened, particularly if it's your first model like it was mine. Take the feedback as constructive and part of that learning journey. And yeah, so I just wanted to say thank you so much for the invite. I published a model. I'm a clinician, not a mathematician, and so if this is your first try as well, you can too. And that my next steps are going to be exploring mechanistic models, so I'm pretty excited. So thank you so much for the invite, and thank you to my supervisors, so Stefan and Christine Statz and Chris Fraser and Sonia Stacey, and thank you to CRE Reduce for inviting me to present today.
Thank you very much, Rachel. It's an excellent presentation. Now, does anyone have any questions for Rachel based on her presentation? Nothing from here. Can you check just on the chat? We're all good. Okay. So I guess, so Rachel, my question when I was looking at the process, busulfan has a genotype that you were talking about at the beginning, the slow and rapid metabolizers. Were you able to see an association with the clearance, certainly from those early stages, or was that something that you were able to incorporate into the model?
Yeah, it's a really good question. So from my prospective group, we have collected pharmacogenomic samples. We are applying for funding to be able to actually run those and then incorporate that into our model. And we've also developed an assay for 3 different metabolites, which we are then once again, like we've done some we've validated the assay, but then we'll be moving on to actually use, looking at that prospectively as well.
Yeah, excellent. And then practically, you were saying that, so what a difference between that laboratory data. As a laboratory-based person, that's so concerning. But practically, as a pharmacometrician, do you think there could have been different strategies? Like, I guess it's, there's the challenge of there was the data from one lab to start with, so you couldn't have split the data sets. But yeah, what was your feel for how you'd approach that?
So I guess what we had considered and put forward as an option was to send some samples from our lab that we had tested and do a validation that way, and see if there was some, particularly for the higher levels, whether there was some factor that we could use as, it appears to be measuring about 80% of what we are measuring, or 70, 85, or it might be on the lower end, and use some kind of factor to then be able to incorporate those higher levels. That was our initial thoughts. But yeah, any other ideas, obviously we would be very interested to hear if anyone else has come across this as well. Yeah,
I think that would have been a good strategy, even using quality control samples, so that the laboratory could have sent them to for an interlaboratory assessment. But yeah, that's a real challenge in the practical world, isn't it?
Yeah.
We're just going to try the mic. We've got a bit of a question. We've got a question for you, Rachel.
Okay.
Nice presentation. Thank you. Regarding the assay, it's always been a common issue when we merge data sets, but the FDA standard acceptance criteria is always like this, with this 15% variability. I know with the done parametric approach, there are ways of trying to account for assay variability or modeling the residual variability. With the parametric approach that you've taken, is there a way to account for assay variability, like modeling the residual variability?
Yes, so we did do that, and there was variability. There was higher variability with the second laboratory compared to ours. So compared to lab 1. So we did do that, but it still was not. It didn't account for everything. And so we further, it took a lot of exploring to eventually come up with the central volume of distribution. If we separated that out by lab, that kind of ended up resolving the issue, and that's where the hypothesis was that it was potentially mainly the higher concentrations that were being underestimated. Yeah. But you're right that we also did separate it out with the residual variability by laboratory.
Yeah, great. Thank you very much, Rachel. Really appreciate your time today and joining us.
All right, thank you.